Okay, so last time we spoke about chest X-rays on ITU. Now I would like to focus on CT, but I cannot resist it. I'll show you a couple of X-rays as well. If you want to look at a CT scan, it's important you are aware of the key anatomy, and looking at a 2D image of a 3D object. It's just one slice, but if we scroll through the images, we can actually get that 3D visualization in our heads. I think what is important is to correlate what we see on X-rays and CTs. So CT is obviously a superior method. However, sometimes you need chest X-ray to understand what you are looking at CT, and vice versa. Knowing the mediastinal anatomy and the anatomy of the vessels and the variants, it's very important. Sometimes you see a cannula in a very strange position, center line going left to the heart. It's still okay because people can have left-sided SVC. It's good to know mediastinal compartments, and this is a link for mediastinal compartments that can help you to understand what you are looking at on CT scan. CT image is a cross-sectional imaging, and we are usually looking at images in axial plane. It's like when you cut or slice a cucumber, you get a slice and you look into it. But nowadays, and it was invented in 1970s, and the technology wasn't advanced that much, but nowadays, 50 years down the line, the technology moved on, and we can actually assess the human body in basically in any plane. I'll show you examples later on. CT assigns grayscale to a pixel according to the density of the material within it, and the density is measured in Hounsfield units, HU. So in some reports we might see HU, that stands for Hounsfield units. Water has a value of 0, so that's water. If you can measure the density and it's 0, it's water. Fat has lower density than water, so it's typically between -20 to -50 Hounsfield units. Soft tissues are denser than water, typically from +30 to 100 Hounsfield units. And if you give injection of IV contrast, soft tissues enhance, they get denser, so the densities might be different. Air has negative values on CT, but it's much more than fat, so typically -700. But the clear air, I'm not talking about lung, should be -1000. Bone is on the other side of the spectrum. It's positive, but much denser than soft tissue, typically 300 to 1000 Hounsfield units. Blood is slightly denser than water, somewhere between 30 to 75 Hounsfield units. But if we see large vessel with content that is 30 or 40 Hounsfield units, it means that patient very likely has got anemia, and it should be 50 and more. We don't give you hematocrit values just based on CT, but we can tell you if they lost a lot of blood, unless they're given contrast. You can actually measure very easily the density. It could be a cursor, a pointer to hover over the area, or you can put a circular measurement and find out what that's the region of interest to measure the density of that area. It's important to avoid partial volume artifacts. So if you place that region of interest into lung, you include part of the mediastinum or rib next to it, you'll get actually average density, and it might be completely wrong. So this is the example. As you can see, the room air is black. That's the density minus 1,000, around minus 1,000. You can see the resolution of the CT scanner. You can even see a thin sheet covering the patient. The air in airways, in healthy airways, is black as it is is the surrounding air. The lungs are still quite dark, but if you measure the density, it's a bit higher because lungs contain vessels, blood, unless there's a consolidation. Okay? So you can easily compare it. And this is what I actually have not commented on. For a review of CT images, we use different windows. So the previous was a lung window that's perfect to assess the lungs or air-containing structures. But to assess soft tissues, you need to use soft tissue window, so you can see nicely mediastinum, large vessels, lymph nodes, airways, but we can't really assess the lungs. We need to use a different window. As you can see, we have some dark structures, quite hypodense, and that's the fat. So this is subcutaneous fat. We have also mediastinal fat. So unless there's a pathological process, the density of the fat in the mediastinum should be similar or the same as the fat just under the skin. The soft tissue structures in the mediastinum, they have a density that is quite similar. This is a contrast study, so it should enhance the same way as the muscles. Yeah, so that's how it should be. Obviously, if we get contrast, the vessels, as long as they are patent, they're enhancing. If they're not enhancing, there's either failure of the vascular access or the pump that is being used, or there is a clot. And we can also do CT scans without contrast, and this is quite interesting. When I receive requests from junior doctors who would like to do a scan and would like to do it with contrast. And actually, it's my job to decide. And yeah, it's always better to give contrast, but there are situations where we can't give contrast. It could be renal function, it could be really poor vascular access, could be severe allergy, but there are also situations where we don't want to give contrast. And that's, for example, if we want to assess just the lungs, we don't need to assess the vessels. So we don't need to give contrast, and that's fine. But even in acute settings, if we're looking for active hemorrhage, and it doesn't matter which part of the body, the principles are always the same. We just do a non-contrast study. You probably have seen intracranial bleeding, looking at epidural or subdural or in subarachnoid bleeding. It's hyperdense. It's a non-contrast study. So the same thing is in the chest. And what I would like to say, it could be a situation you cannot give contrast, but you would like to know more what's going on. I still would say let's do the CT. In some cases, it's quite rare, but even large clots in pulmonary artery can be seen on contrast scan. Yeah? I'm not saying we don't need contrast. I know there are studies with artificial contrast, some kind of AI technology. I have some reservations if we want to know if the blood is flowing in. We still need to inject. Yeah? But there are situations where, for a reason, you can't give contrast. The CT still can give you answer you are not getting from chest X-ray. If we want to assess lungs in detail, we use HRCT, which is a thin slice CT with a special algorithm. So since 1970s, the technology has moved, and almost everything we do is a thin slice. We do 1 millimeter slices, and we can do the HRCT, and we see often things even if we don't want to see. Our resolution is very, very, very good. There's one thing that is quite interesting. The lungs, because they contain vessels and there's blood flowing in, they're also enhancing after contrast injection. So if you really want to assess the lungs in detail, you should do it without contrast, yeah? Because sometimes you can have increased density and it gives you appearance of ground glass opacities, and it might be a false positive finding. And it's just enhancement of the lungs. So this is CT of the chest in mediastinal window. So we see larger vessels in the lungs, but we can't see the structure of the lungs. So we can distinguish ascending aorta, pulmonary artery, and descending aorta. When we switch it to the lung window, we can beautifully assess the lungs. So we know that the patient doesn't have emphysema, just a little bit of emphysema. They don't have pulmonary edema or other conditions. But the assessment of the mediastinum or bones is really limited on this window. When we give contrast injection, we actually can scan the patient in different phases of contrast enhancement. And in the chest, we have basically 3 phases. First is pulmonary arterial, which will be used for CTPA. So if the query is PE with amazing, very good enhancement of the pulmonary artery, we have relatively good enhancement of the aorta, but it could be better. And we have loads of dense contrast that is still flowing into the patient in the SVC. We can, so this is roughly 23, maybe 25 seconds after the start of the injection. If we start scanning a bit later, 25, 30, we get arterial phase. So you can see nicely ascending aorta, descending aorta. We still have relatively good enhancement of the pulmonary artery. If you compare it with the previous, it's not. We saw on the previous phase, and so we don't have that dense contrast in the SVC. We occasionally get query: is this aortic dissection or is this PE? Can you rule out both? Well, we can try, but we prefer the patient is really assessed clinically, and I would say in the vast majority of cases you can clinically say this looks more like dissection rather than PE. We had patients who were scanned for PE, obviously were given dalteparin before that, but even reading the history was suggestive, well, this is more dissection than PE. So we did CTPA and there was dissection. We can distinguish it. What we really need is to have a good clinical history and use your experience. What do you suspect? What do you want to really rule out? And we'll protocol it accordingly in order to try to answer your clinical question. Obviously, cannot avoid it every single time. So there are situations when we're using wrong protocol. We need to recall the patient, or the images might be sufficient to make the diagnosis. The third phase, typically 60-70 seconds delay after the contrast injection, is portal venous phase. So we have enhancement of SVC, ascending aorta, and pulmonary artery that is equal. Yeah, it's the same. Can we rule out, for example, aortic dissection or a PE from this scan? Yes, but we might be missing some things. So it's important to know what the clinical information is. One thing I would like to comment on is the quality of vascular access and the function of the heart. If we're scanning someone who has, for example, low left ventricular ejection fraction, we might be aiming for a PV phase. We still get arterial phase because it takes time for the heart to pump the blood with contrast. So we can see that. Okay, when I show you a CT scan and you want to have a look at it because it takes radiology too long, or you want to revisit something, it's good to have some kind of systematic approach. You don't have to use this particular approach, have your system. It's the same principle with chest x-rays. Yeah? You go from A, B, C, D to Z, or whatever you have there, or have your checklist, or the chest x-ray reading report approach is inside out or outside in, having a system in order to not miss anything. So in the settings of intensive care, I think a good practice is to start with lines and tubes. Your massive advantage, as opposed to radiologists, is you know what is in. And if you're not sure, just have a look at, yeah, there's a tube in, or there's no tube, so this is just artifactual or external line that is not there. This is something we sometimes might struggle. Then you can assess parenchyma for consolidation, ground glass opacities, nodules, masses, interocular septal thickening, typically seen in interstitial pulmonary edema. Then you can go to airways, and because you do bronchoscopy, basically reading CT is like doing a bronchoscopy. You start from the larynx and you go down to the airways, and you are looking for abnormality, and we see exactly the same thing as you do when you do bronchoscopy, but with the blood on our images is not red. I think that's the main difference. Sputum is not green, everything is gray. When looking at the mediastinum, check if the fat is clean. Compare it with the subcutaneous fat, as we saw it earlier. Look for masses, presence of lymph nodes. Is there air? Don't forget about pericardium, the fluid thickening, calcification, blood. Assess the heart. If you want to really assess the heart in detail, you should be doing cardiac CT, that is usually ECG gated. The standard scans we do for your patients is not ECG gated, and you have other ways how to look at the heart, but still, it's the heart is there. It's a static image, so we don't know much of the function, but you can see if the cardiac chambers are dilated or small. You can assess the position of the interventricular septum and so on, and presence of clots, for example. However, before you start calling something a clot, to make sure this is not just an artifact. We have when the non-contrast blood and contrast blood are mixing, it actually might get the impression there is a clot. Just it's like two big rivers, their confluence, they still flow for a couple of miles. You can distinguish the colors. The same thing can be happening, for example, in the SVC. So we are injecting into the right arm. So from the right brachiocephalic vein, we're getting contrast blood, and from the other side, from the left brachiocephalic vein, you're getting non-contrast blood. And is it a clot? No, it's just non-contrast blood. And don't forget pleura. So we're looking for fluid, air, blood, presence of nodules, thickening. And what I didn't include is obviously the bones. Also need to assess the bones, look at the spine. That's like on chest X-ray, we have some review areas where we tend to miss things because two big lungs and a heart in between, and we're happy with everything. But there are also other structures such as esophagus, the diaphragm. The diaphragm is a bit tricky to assess only on axial in axial plane, so it could use other planes as well. So supraclavicular fossa, that's we often miss. Lymphadenopathy, for example, or in case of ITU patients, it could be a hematoma, for example. The heart, large vessels, lower neck. We also visualize the lower neck. There could be a pathology there. We also visualize upper abdomen. We need to check what is there. And I mentioned that you need to check the bones. I use a rule of 3 when looking at CTs, and it's review in 3 different windows. It's the lungs, mediastinum, and a bone window. If you review it only in one window, you might be missing significant findings. I also use at least 3 planes. So the axial, this is how we send you the images. It's that sliced cucumber. But we can reconstruct that cucumber in the computer and see from other perspective, and suddenly we understand anatomy better. This is what all radiologists do, and I'm certain you do it as well, but I would like to stress it. We have complementary roles of the imaging methods, and it pays off. Most of the patients with acute chest symptoms will have chest X-ray first. I think it's still a good starting point. We can use it for planning of the CT scan, for example, which phase, or do we need contrast. That's quite useful. Chest X-ray, in particular portable chest X-ray, can be misleading. Should be always reviewed, and I'll show you a couple of examples. Ultrasound. So it used to be our imaging. Now you have ultrasound yourself, and ultrasound became a stethoscope of 21st century, and you're more now confident scanning the lungs than most of the radiologists. And as you know, ultrasound is operator dependent. and we have physical laws that limit use of ultrasound, so we can't go through the aerated lungs or through bones. And if you have someone who's very large, it might be really limited. CT is usually better in assessment of structures that are deep. CT is normally, and it is not just seen, but it is a superior imaging modality. But in acute care, it's just a contrast, but in particular in our hospital, it's the transport. And it's almost like big military exercise, taking someone who's on ECMO and taking them into the lift, going by the shop, by the bus stop, visiting the Bradgate Park, and then finally reaching the CT scanner. I know it's exciting, but if you think what can happen, and sometimes things do happen, the best thing, I'm not sure if that happens before I retire, the best thing would be to have a scanner next to your neck. More time, and you won't have problems with the lift, other things. From my point of view, the best practice when you're assessing imaging, trying to figure out what's going on, to use all the imaging there is. Yeah, that's why we have PACS. I know you are not sending your echocardiograms or ultrasound scans to the PACS, but you have access to X-rays, CTs, and as we do in the radiology round, we occasionally look back. There could be a CT telling us, oh, there was advanced interstitial lung disease last year, and it might change your strategy. So now I would like to make it a bit more interactive. There's a possibility, because I showed this image in another meeting, so some of you might already remember it. I know this is not a great visualization, but my query is, if you strictly adhere to our guidelines about NG tube, if you are happy, I can see it on this screen. What I'm going to do, I'll show you also the negative of this X-ray, so you probably can see it. What are you going to do with this NG tube? Are you happy or you are unhappy? Okay, I'll tell you what happens in this particular case. Yeah, and actually, question is where that NG tube is. Yeah, we can see the trachea. This is the carina, right main bronchus, and the left main bronchus, and it follows that left main bronchus. So where is the rest of the tube? But if you think about such a big loop, is there that much space in the lungs? Unless it was a pneumothorax. Yeah, so unfortunately, our patients don't follow our guidelines, and everyone is unique. And that was a CT that helped us to understand what was going on. Patients had hernia, and I don't have that scan that esophagus was actually pushed to the side. So this is in the esophagus, and this is in the stomach. Yeah. So there was an email shootout. Why radiology didn't comment on that, and should we take it out? Yeah, you can take it out, but you'll end up staying in the same position. Just that, well, for a radiologist, easy thing. For you guys, if you're busy, it might be a bit more difficult and you can't get access to the computer straight away. But having or reviewing previous imaging stops you from taking that NG tube out. This is the position, the best position for this patient. It is definitely in the stomach, that happens to be above the diaphragm. Yeah? And somehow we managed to visualize the NG tube mimicking the course of the large airways. So sometimes it happens. So who can tell me what happened to this patient's liver? Anything exploded there, or is it exploding just now on the scan, or what is it? What happened? Who can tell me? And this is CT. That's a superior imaging. It didn't give contrast, but it's the best imaging you can do.
Yeah, and I'm going to be a pain and say what you would tell me, which would be, can I have some clinical context to this, please?
All right. Yeah, but it was really bad referral. Just saying that the patient has abdominal pain, and that was it. Really
That's an
close.
awful referral.
Yeah, I know. Welcome to my world.
I was thinking it looks too organized, like the lines that come out look too organized to be something like, cannot be something that is like an interference or like an artifact.
It's called beam hardening artifact or streak artifact. So yeah, I agree. There's something that is very dense, and it's even denser than the spine. Yeah, so it must be metal. But is it in the right place? Probably not. So sometimes it feels like chest X-rays are dead. We'll do CT. Why bother with X-ray? So we did chest X-ray, and now you can give me your diagnosis. No.
Bullet.
Yes. England. No. Oh yes, yes. It should be just a knife. Yeah, not a bullet. Yes, but people travel around the globe, and some of them are bringing shrapnels and projectiles in them. But I just wanted to demonstrate. Yeah, you can spend a long time. What is that? What happened? Just look on the chest X-ray, and it's there. Presence of pleural effusion. So sometimes X-rays, in particular AP projection, supine, semi-erect, could be tricky. Yeah. So from the X-ray we can tell there is some effusion, but not probably not much. With the CT, that there's much more. But the next question is: are there any septa? Well, I don't know. There could be. So unless there are multiple gas bubbles, it's very difficult to comment on presence of the septa, and you want to know it for the future management. And the easy peasy thing is just do the ultrasound. Every imaging modality has its weaknesses and strengths. The best thing how to use it is to review everything you have. Then you get the results. I met some clinicians who were very confident, I would say overconfident with ultrasounds, who were even correcting CT reports. I equally met with some radiologists who were really confident about CTs, and then you do ultrasound and it's a bit different. Yeah? So this is how it should be done. Okay, patient probably 9-10 years ago on this unit, someone who had cardiac surgery, and after cardiac surgery they developed hemoptysis. So this is not the best phase, but this is what we've got. But can someone tell me why they developed hemoptysis? Can you tell from those two slices? It's hard. So it's this, yeah. There's an enhancement, and it's actually a pseudo-aneurysm of the branch of the pulmonary artery. And we shouldn't have such a big vessel here, and it's just like that. It's a pseudo-aneurysm. Why they have a pseudo-aneurysm? We tell no. But when you review the chest X-ray, the answer is It's simple. Yeah, PA catheter went too deep and injured the pulmonary artery. This is an elderly patient, and so I recently checked their imaging. They're still alive. Yeah, so they had surgery. Their heart was repaired. We injured the pulmonary artery. The vascular radiologist, they embolized it, and the patient leads a happy life, which is great. But review in a series of X-rays, understand what really happened to the patient, then you will understand it. With nowadays CT scanners and computers, we can do all those fancy things, and the clinicians are always impressed. And can we get 3D images? And yes, we'll do it, and you can color them different ways, and it's fancy, and everyone is excited, and that's great. Yeah. So we know the patient has a fractured scapula. Yeah. You can even see it on just coronal reconstruction, broken ribs. Yeah. So that's what we can see. But actually, it's all visible on X-ray as well. So a bit skeptical about those really fancy images. They can help. In particular, if we're looking for rib fractures, or if cardiac surgeons want to see abnormal vessels and relation to the sternum, or they do redo sternotomy, stuff like that. But I would say always start with chest X-ray. It can help you. Another case that was during the pandemic, so we are familiar with these images. Someone who has diffuse alveolar damage, or clinically ARDS, and they have ECMO cannula. I think everyone is happy with that. Just inverted it. It's exactly the same image. It's clear, and because there are critically ill patients, they have series of X-rays. So we're happy with this chest X-ray. Are you happy with this chest X-ray? Or is there anything you're a bit unhappy about the ECMO cannula? Everyone is happy. Yeah, it's in. That's what we want. Yeah, and it's working. Yeah, I know radiologists don't know how ECMO circuit works and how to operate it. You know that, and you obviously can check if there's a good flow, and if that cannula goes into the hepatic vein, it might not work as it should. So you check the imaging, it might correct it. It was working beautifully. Yeah. The problem is the way it goes to the side. It was actually missed. Yeah, it wasn't commented on because it's extremely rare. But what happened? Yeah, this is how it looked on CT. So that was a very sad case of a lady who I'm not entirely sure, but I think they're moving her somewhere, and the ECMO cannula got dislocated. It was pulled out partly. They pushed it in. What happened? They went through the right atrium into the pericardium. Yeah, so it can happen. It is all on chest X-ray, but sometimes we fail to appreciate the change. It's a series of images. So it's present. Yeah, so this is how deep it went into the pericardium. It was still working fine. This is another case, and this time I didn't bring chest X-ray, but this is a case that I often show to radiologists because on serial imaging we failed to understand that there was a major problem. So I accept it's only 3 CT scans, 3 CT slices, but can you tell me what's wrong with this this patient. There's something really wrong. Situs. Well, we're a bit above the diaphragm, so the level. So this is aortic arch, heart.
There's some air in the subcutaneous tissue.
Yes.
At the top.
Yeah, but surgical emphysema is, well, it's quite common, and I can tell you this patient just had surgery, so we still can see some surgical emphysema. But this is not a reason for concern. You know what this line is? Say it again.
Is it a Jagus lobe?
Well, it's similar, but it isn't. It's just too big. It's a fissure.
Yeah.
The question is, should that fissure be that high? There's something wrong. Everyone described it, yeah, and we have abnormality, we have septal lines, ground glass opacities, consolidation. There's something going on.
Like a pulmonary contusion.
Not entirely, but this is the contrast. This is the sagittal view, another sagittal view. But one fissure, another fissure, another fissure. There's something going on. We're nearly there. It was hemorrhage. What do you think about the pulmonary artery?
It's an infarct.
Well, it's infarcted, but the whole lung is infarcted.
Yeah. So nick in the pulmonary artery causing infarct.
Is it clamped?
Oh, clear.
No,
Has it been sutured?
no. I should have brought some chocolate. This is extremely rare, but this is lung torsion. Yeah. And you know the anatomy is wrong. There are fissures in the lung is congested. There was hemorrhage, but there was no blood flow. Yeah, it was 70 degrees. So it was a complication of our Lewis procedure. It's extremely rare. Unfortunately, it wasn't recognized on chest X-rays. It wasn't recognized on 3 CT scans. Yeah, the abnormalities were described, but no one really put it together. So that lady unfortunately lost the lung. And this is the CT after that lung died. So there's no enhancement. They're just consolidations. Dead lung. And it was found at one of our radiology meetings, unfortunately, a couple of days after the surgery, so the lung was dead completely. But I think this is the role of communication, radiology, clinical team, and in particular ITU. You work extremely hard to save lives of your patient. Amazing job. Our advantage is obviously bigger screens, but also some experience in putting things together. And there are situations that it really pays off to talk to us. We might get some extra information from you that is not on the clinical on the request, and we might say, oh, that could be this, and you say no, this is not pulmonary edema because they're dry as they could be. Could that be anything else? And then trying to narrow the differential diagnosis. So this time the ECMO cannula, well, it was a bit higher, but it was working fine. So that's fine. But that patient is a young chap. And if you want more details, speak with Cass. I think that was her first ECMO patient, if I'm not mistaken. So the lungs look relatively okay. Obviously, we have ECMO cannula, we have large chest drains, and then we have those opacities. Yeah. So what is that? We knew that this was someone who was a recreational drug user. So if you say they're taking drugs, they could be HIV positive, and we have ground glass opacities in upper zones. This PJP usually happens at radiology conferences. Yeah, those who can distinguish it, they usually get an award because they nailed it. Yeah, so with it, well, this is inverted. You still see bilateral abnormalities. We did a CT, but there were no clever. So there was still that pneumothorax drain that traveled into the fissure, but that's fine. Lung really expanded, and still quite weird ground glass opacities. It's strange, and it's bilateral pneumothorax, bilateral chest drains. What happened? Who can tell me? Probably didn't see my presentation chest X-ray, so I showed this as well. This is the process understanding what we are looking at. So ground glass. Ground glass could be from A to Z. It could be alveolar hemorrhage. It could be bronchoalveolar. Today is adenocarcinoma. It could be pneumonia. We'll say viral pneumonia, PJP. It could be radiotherapy induced. Yeah, you can get pneumonitis. You can have interstitial lung disease. It could be anything. Yeah? But we need to get to the bottom of the things. So we go to a different plane. What was interesting, actually, both drains traveled into the fissures, but that's fine. And it's upper zones, and we have this dense line and this dense line here. So if I tell you that this is the second intercostal space anteriorly on both sides, and we have linear opacity in the patient. So this child presented with life-threatening asthma. We actually have, this is airway disease, yeah, thickening of airways. In the emergency room, someone came to a conclusion that this could be bilateral tension pneumothorax. So, well, I think this was fed back, not the best practice, but I've seen it before, and I accept in the heat of the moment, if you need to do something, you do it. But we see drains being put into the lungs, and the person who does it says, "Oh, it drained air and blood." Yes, so it must have been traumatic pneumothorax. No, they're draining the lungs. And exactly the same thing happened here, and it was reported, PJP and whatever. But this is injury to the lungs that caused pneumothorax and lung hemorrhage, and he was brought in. So yes, we can do all sorts of fancy images. So this is not in colors, but still very nice. This is called maximum intensity projection. It's in the coronal plane, so you can see the pulmonary artery and large filling defects in reflux of the contrast deep into the hepatic veins, just tricuspid regurgitation. So that's great. However, when we looked on the X-ray, this is Westermarck sign. And there's no perfusion. So even from a chest X-ray, ideally we should compare if we have previous, and we suddenly see there are no vessels. This is PE. So yeah, I'm not saying chest X-ray I can replace CTPAs. No, but you can get that information as well. Challenges of CT scanning of critically ill, well, as you well know, there are many challenges. The biggest problem is scanners are not portable, although in some countries where they can afford it, they use portable scanners for CT of the head. The radiographers complain about it because it's very they usually get the backaches. It's heavy to handle it, so If you worked in the United States, you could have seen it. It's the same thing like X-ray machine. It's just bigger, heavier. There's a lot of radiation, and it's a small scanner. It's just for the head. You can't do the whole body. But I understand that argument. You don't want to travel around the hospital with someone who's critically ill and you're treating them for serious disease. But in the for the future and for those who plan new hospitals or trying to reconfigure the old hospitals, I think big units like yours should have a scanner next to it rather than going all that process coming downstairs. Size of the patients can be a massive issue. We had that issue, and there's always that conversation because it doesn't happen every day. So ITU rings CT, and you scan a patient who is 280 kilos, and the radiographers answering the call say, "Oh, I don't know. I need to ask our superintendent." The superintendent says, "Yes, we can't guarantee the correct movement of the table, so it might display the images, but actually the weight itself is not that big issue. Obviously, we prefer to not scan these patients, but we can. But the limiting factor is their size. It might not fit in, and it's someone who's very ill." And it takes you to get them ready maybe in 45 minutes. Yeah, during the pandemic, I'm not sure if anyone remembers that during the pandemic, the security had to actually block the corridor all the way to the scanner. Yeah, it was a military style operation. People with walkie-talkies, have they passed it? Not. American president visiting the hospital. It was so complicated, and you don't want to do that with the patient when you manage to put them on the table and we say, we can't get through. The simple thing is to take a cardboard and measure the gantry and have a look at your patient. Can you fit them in before you start transporting them? So that's just a little bit. Vascular access, ideally green cannula in the arm. I know that not every patient can have that, and our radiographers often ask for a cannula even if they're central line. You can guarantee us that line will take the pressure of the pump. Mind you, we're sometimes injecting dense contrast in 5 milliliters per second. So it's a massive flow. If that center line can take it, I think the Pascat probably can do that. We can use it. We are giving nephrotoxic contrast media. Usually it's on the floor. Happy to there is. I still would say question what the clinical question is. Maybe to answer it, you don't need to contrast. That's another thing. In most of the cases, we do contrast. Artifacts. So not everyone has got a bullet in their bodies, but the lines, tubes, and actually the fact that there are artifacts that they put their arms around the body. We have lots of artifacts that can limit the scan. So to conclude, CT is a fantastic imaging method. That's why everyone wants to do a scan too. Might not always answer your question. The previous imaging also helps. Nowadays, because we have scanners everywhere, we scan quite a lot of patients. we sometimes even find things we don't want to know about. Yeah, so you do CTPA and you find multiple metastases in the liver, yeah? Or you scan abdomen and for cholecystitis, and you find nodules in the lungs that need follow-up. Comparison with other relevant imaging, it's really important. Was it there before, or was there a significant abnormality before they developed ARDS with bilateral whiteout? We really need relevant clinical information. I accept sometimes it's not possible. The requesting system is not always the best we've got, but that's it is. But we really would like to know why we're doing that scan and what do you expect from that. And if we can have requests like that, we'll probably produce slightly more useful reports. And before you come downstairs, you can just chest X-ray or ultrasound answer your question. In many cases, they can. So that's all. Do you have any questions? Anyone from audience?
One question, it's not related to scanning of the chest. Sometimes with the abdomen, we ask for triple phase CTs. What I don't understand is, what are those phases? When do you request for a triple phase, and when do you not request for a triple phase? Is it the same as the 3 phases that you show for a CT test?
So we normally don't scan chest in 3 phases. Triple phase is typically used for hemorrhage, for active hemorrhage, if there's anything that can be embolized. And there are some indications to assess lesions in the liver or adrenals where we have more phases. But depending what is the clinical question, yeah. So I would suggest to focus on the clinical question. I will try to answer rather than how we should. Yes.
I leave that to you.
Yeah. And everyone is trained in doing that. So I'm looking for active hemorrhage because the patient is losing hemoglobin and would like to know if there's anything. So don't tell us what to do, but what do you want to know?
So it's the same phases though. It's venous, arterial, and portal venous. For the abdomen?
So for the abdomen, it would be non-contrast. If you are looking for bleeding into the gut, there are in feces, there could be bits that are hyper intense and can be mistaken for bleeding. It could be, for example, capsule or tablet or whatever they swallowed. And if we look on the non-contrast scan and it's not there, then in arterial phase you see a small, small amount of dense material, and then on PV phase it gets bigger. That's the thing. Right. There's an important thing, and I accept in intensive care it's a bit different. You're trying to save someone's life, so I'm not that concerned about the amount of radiation. But doing 3 phases, that means the triple dose, standard scans. So abdomen and pelvis we normally do in PV phase only, and it should answer all the questions: malignancy, abscess, bowel obstruction, perforation, portal vein thrombosis, for example. It should answer that. If your query is bowel ischemia, it's a bit different. We want to have a good enhancement of arteries. It's SMA occluded, and then is the bowel enhancing. So sometimes we do 2 phases. in most of the cases for bowel ischemia, still the PV phase should do the trick. So yeah.
Thank you.
We'll be talking about the background behind the trial, the design and results of the trial, and the relevance to our practice in the intensive care units. So the clinical question this trial asked was, does reducing exposure to supplemental oxygen by using reduced peripheral oxygen saturation target of 90%, using a range of 88 to 92%, decrease 90-day all-cause mortality in mechanically ventilated adult patients receiving supplemental oxygen in the intensive care units? Now. Okay. How did you do that?
I don't know. I just maths.
So the background is that we know that oxygen is the commonest therapeutic intervention in intensive care units. We know that too little is harmful to patients, as it can cause cellular hypoxia and organ dysfunction. And too much is also harmful to patients by means of production of reactive oxygen species, causing cellular damage, absorption atelectasis, acute lung injury, central nervous system toxicity, reduced cardiac output, and cerebral or coronary vasoconstriction. Previous trials have tried to find the optimal oxygen saturation target in critically ill patients. I went through a few and we'll put the references at the end, but basically they have conflicting results and kind of different methodology. The oxygen ICU trial showed that lower oxygenation targets demonstrated mortality benefits. However, it was a single centre study and underpowered. ICU-ROX did not demonstrate any difference in ventilator-free days between conservative and usual oxygen therapy. Hot COVID showed conservative oxygen therapy resulted in more days alive without life support in the ICU. And the liberal or conservative oxygen therapy for ARDS, there was no difference in 28-day mortality in this trial, but the trial was stopped early because there was an increased 90-day mortality and rates of mesenteric ischemia in the conservative oxygen therapy group. In 2024, they did a meta-analysis involving 13 randomized controlled trials involving 10,632 patients. Conservative oxygen therapy did not reduce all-cause mortality in ICU patients, and they identified a need for further randomized controlled trials to confirm the impact on conservative oxygen therapy strategies in specific populations. Coming back to the UK-ROX randomised clinical trial, the design was that it was a multi-centre, pragmatic, randomised controlled trial conducted in 97 ICUs in the UK, as I said, including the ICUs locally. Participants were recruited between May 2021 and November 2024. And the sample size was 16,500 patients, and they were randomised 1-to-1 to receive either conservative or usual oxygen therapy until ICU discharge or 90 days after randomisation. Unlike some of the previous trials, the UK-ROX trials included studies into diagnostic subgroups, and they included sepsis, hypoxic ischemic encephalopathy, acute brain injuries except hypoxic ischemic encephalopathy, confirmed or highly suspected COVID-19, or none of the pre-specified subgroups. To be included, you had to be critically ill adults aged 18 or older and receiving invasive mechanical ventilation following an unplanned admission to the ICU, or where invasive mechanical ventilation was started in the ICU and receiving supplemental oxygen. The exclusion criteria were if you'd been randomised to the UK-ROX trial in the previous 90 days, if you were receiving ECMO, or the treating clinician considered that the intervention was contraindicated. Randomisation occurred as soon as possible after confirmation of eligibility, and they were randomised 1-to-1 to receive either the conservative or the usual oxygen therapy. allocation concealment occurred by concealed central 24-hour telephone or web randomization. The allocation was not blinded, and randomization used permuted blocks with variable block sizes stratified to site and diagnosis to give balance between units. The conservative oxygen therapy group received the lowest FiO2 to maintain SATs at 90%. So monitor alarms were set to alarm if SATs went below 88 or above 92, with the upper limit deactivated if a patient receiving FiO2 of 21%. Deviations were allowed if there was a major discrepancy in blood gas-derived oxygen saturation or if there was a life-threatening event necessitating higher SpO2. The usual oxygen therapy group just received standard care, and participants received supplemental oxygen at the discretion of the treating clinician. There's no minimum FiO2 mandated and no upper SAT limit monitor alarm set. The primary outcome was all-cause mortality at day 90 after randomization, and there were no differences between groups. 35.4% died in the conservative group versus 34.9% in the usual oxygen therapy group. And after adjustment for pre-specified baseline variables, the risk difference was just 0.7%, and that was with a confidence interval of 0.6 to 2.1%. There was no differences in the primary outcome when the diagnostic subgroups were considered either. In terms of secondary outcomes, there was no difference in duration of ICU or acute hospital stay, days alive and free from organ support at day 30, mortality at ICU and hospital discharge, or mortality at 1 year. I think the strengths of the trial was that it asked a very important clinical question. Despite oxygen being the commonest therapeutic intervention, more is needed to know about the optimal dose. Even if there was just a very small survival benefit, it would equate to a lot of patients because of how many patients receive oxygen in the intensive care unit. And there is a gap in the data about specific populations and what their target oxygen saturations would be most beneficial for them. Another strength was the size of the trial. So if you consider that the meta-analysis just had over 10,000 patients previously, this trial had 16,500 patients, which provided 90% power to detect an absolute risk reduction of 2.5%, assuming a 6% loss to follow-up. So therefore, the trial was adequately powered to detect clinically meaningful outcome. The trial is there's good generalizability, so the sample of participants was highly representative of the whole potentially eligible UK ICU population. And there was good internal validity. So, as I said, there was allocation concealment, there was strict adherence to intention to treat analysis, and there was near complete follow-up, with only 0.6% of the participants having missing primary outcome data, and over 13,000 tracked to 12 months. And another thing I included in the strengths was sometimes when trials are compared to usual care, the participants in the trial can get very similar treatments, but you can see that probably because the protocols were good, that the conservative oxygen group did have a lower median SpO2 and spent significantly more mean hours in the target range of 88 to 92%. So if there was the difference, you could more easily attribute that to the intervention. The weaknesses were that the clinicians were unblinded, but as mortality is an objective outcome, I think it's unlikely that the trial would be influenced by this. There was no adjustment for oxygen exposure prior to intubation and randomization, which obviously can influence outcomes in critically ill patients. And so there was some enhanced data collection in 2,500 of the first patients randomized, looking more closely at adherence to the trial procedures. And 42.1% of the patients had a period of non-adherence, equating to 10% of their ICU time. But for me, because there was good therapeutic separation, I don't think this was a particularly bad weakness. The conclusion of the trial, of the UK-ROX trial specifically, was that reducing exposure to supplemental oxygen by using reduced peripheral oxygen saturation target of 90% showed no reduction in 90-day mortality, no difference across diagnostic subgroups, and no difference in any of the secondary outcomes. But equally, there was no major statistically significant difference in serious adverse events. And this adds to the existing evidence that aiming for lower but safe oxygen saturations, such as 88 to 92, is not harmful compared to usual practice. The relevance to our practice is that I think it's not really a debate now that we should be avoiding routine hyperoxia. But with the data that the UK-ROX trial has given us, I don't think there is any specific reason to mandate any changes to our current practice. But I think that potentially that might change in the future. I think if you use if there was like a very large sample size, we might prove more reliably that there is a mortality benefit to have oxygen saturations of 88 to 92%. But what I actually think is more important is trying to figure out what the best target oxygen saturations are for individual diagnostic subtypes. So maybe it will be the default in the future that we use target sats of 88 to 92% and then just change them on an individualized basis for whatever subgroup or population would do better with a higher oxygen saturation. But there is a mega-ROX trial which is going on at the moment, which is a randomized control trial of like 40,000 patients, and they are looking again at mortality benefit of oxygen saturations of 88 to 92%, and then looking into the different diagnostic subtypes too. But that's my thoughts. Does anybody have any questions or any comments that they would like to say?
I had a question, Jeff.
Yeah.
It's okay. One of the sort of, I presume, hypotheses for why over-oxygenation is a negative would be increased exposure to oxygen-free radicals. And would that, so my thought process is, does that increase with time? So was there any analysis of how long a patient stayed on oxygen for, where initially there might not be a big difference, and then in the groups that have been on oxygen for a longer period of time, they might diverge a little bit in the outcomes, or they didn't segregate patients by time on oxygen?
They did in the diagnostic subgroup. They did. I think overall they did, because they were able to say the mean hours of the patients of their target saturations, but we don't know what patients would have had, say, saturations above 96 or 97% for any period of time. I don't think that's was involved in any of the data, to be honest. Does anybody have any of the consultants have any comments or anything? Or if not, we will leave it there.
We had a lot of patients on UK-ROX. It didn't seem to make a huge amount of difference. Oh wait, well no, as in it didn't cause harm, so it was safe to do, I think.
Yeah.
Is what comes from that.
Yeah, that's what the trial.
They're probably all happier to just run at lower sats.
Yeah.
I don't know if the others have anything different to say, but
it was a very useful
it'll be really
trial.
interesting.
Oh, sorry, Jenny.
Sorry, Mike. No, sorry, Mike. Go ahead.
No, Jenny, you're definitely first.
Okay, I was going to say, I think it'd be really interesting to see when the exact arm of this trial reports.
yeah.
So for those people that are not aware, SATS probes may read differently pigmented skin. So black origin patients and Asian patients, of which obviously we have quite a large number in Leicester. there was a lot of concern about whether SATS probes actually overread in those patients. So that's we were one of the biggest recruiting centres to the exact arm, and I don't know when that's coming out, but it should be soon.
Mike?
I was just going to say that it was a really useful trial in just reminding people to bring the oxygen down. You don't have to sit with a load of patients on 100% SATs for the entire time.
Yeah.
And the PO2s are 20.
I turn the oxygen down in theatre all the time when people have SATs of 100 because they don't need it. You end up on quite low oxygen for a lot of them. But cool. Thanks very much, Joe.
Thanks, Joe.
Please use the QR code and do some feedback for Dr. Brozic and for Joe, and then you get a little certificate emailed to you. For anybody that's not here anymore, the link is on the invite to the meeting, so encourage them to do that. That's okay?
Yeah.
And then
Okay.
I forgot what we're doing next week. There is teaching next week. I can't remember what it is. It might be Dr. Bell. Can't remember.
Yeah, it's me doing brain injury.
There you go. Excellent. It's Dr. Bell. Thank you all. Have a lovely weekend.
Thank you.
Bye.
Bye.